guys, welcome back to A to Z Dentistry, a channel which features easy explanation of various medical and dental related topics. And our today's topic is oral hairy leukoplakia. So without any further delay, let's get started. So today we will be studying oral hairy leukoplakia, also known as OHL, under the following headings: Introduction, Definition, Etiology, Pathogenesis, Clinical Features and Management. So without any further delay, let's get started. Moving on towards the introduction. So as the name itself indicates, it's a hairy leukoplakia, right? It is a hairy type of lesion, right? So here in this figure you can appreciate there are hair like projections which are seen, right? So OHL basically presents as a non-movable or non-scrapable corrugated hair-like white lesion on the lateral margins of the tongue. Now this line is very important, that this lesion is particularly present on the lateral margins of the tongue. It can also occur bilaterally, okay, and it is strongly associated with HIV infection. Again, a very important point, right? The first point is it is present on the lateral margins of the tongue, and second is it is strongly associated with HIV or AIDS infection, right? It occurs in all risk group of HIV infections, although it is less common in children, right? In adults it is very commonly seen. However, if a child is infected with HIV, it may not be seen, okay. It occurs in about 20% of persons with asymptomatic HIV infection, and it becomes more common as the CD4 plus T cell count falls below 200 per mm cube, right? So this is very important. So as the T cell count decreases in HIV, as we know that there is a progressive decline in these cells in HIV patients, so this type of lesions becomes more common, right? So it is directly associated with the falling counts of CD4 plus T cells, right, because of the marked immunosuppression which occurs. So as there is a progressive decline in these cells, marked immunosuppression occurs, and therefore such type of lesions become common in HIV patients. Here in this diagram you can see, right, this is present on the lateral margins of the tongue, okay. Then it is non-scrapable, right? It is white in color, and it definitely has a corrugated appearance, right? It has a corrugated surface. Moving on towards the definition of OHL. So basically it is a non-painful white corrugated or hairy type of a plaque which is typically found on the lateral borders of the tongue, and it is caused by reactivation of Epstein-Barr virus, right? So it is non-painful, right? It is a non-painful lesion. It is white in color. It has a corrugated appearance, right? It has a hair or plaque type appearance as well. See here you can appreciate it has a hair like or plaque like or corrugated appearance, okay. And it is found typically over the lateral borders of the tongue, and it is caused by reactivation of our Epstein-Barr virus, right? So it might be possible that previously the person was infected with such a virus, and then because of the marked immunosuppression, right, marked immunosuppression again triggers that virus, and this causes our OHL. It is strongly associated with immunosuppression, particularly in the individuals with HIV, right? But it can also occur in other conditions where the immunity is suppressed, right? So in other cases, particularly for example in case of antigen antibody reactions and all, right, where there is a marked immunosuppression, in such cases also we might encounter OHL. This lesion is not pre-malignant. Again, a very important point, can be directly asked as an MCQ question, right? So this lesion does not come under oral potentially malignant lesions. However, leukoplakia and erythroplakia are oral pre-malignant lesions, right? But OHL is not a pre-malignant lesion. Very important. It does not scrape off like every other type of leukoplakia, right? It is definitely a non-scrapable lesion, right? And it sometimes becomes very difficult to distinguish it from other type of oral white keratotic lesions, right? So it resembles leukoplakia definitely, but you have to look at the location, You have to look at the location. If it is along the lateral borders of the tongue, then definitely it is a case of OHL. And also the hair-like projections, right? Typically leukoplakia appears as a cracked mud-like appearance, right? We have a cracked mud-like appearance, but here we can see a corrugated appearance, and its presence over the lateral margins of the tongue distinguishes it from other types of leukoplakia. Moving towards the etiology or the cause of OHL, right? So this is a diagram of EBV. This is a diagram of EBV, right? So basically it is human herpes virus 4. Very important for MCQ. Human herpes virus 4, also known as gamma herpes virus. Also known as gamma herpes virus, which causes OHL, right? So the exact etiology is not known. However, Epstein-Barr virus has been identified in majority of such lesions. Okay, now there is one hypothesis, right? This states that the basal epithelial cells over the lateral margins of the tongue harbors EBV in majority of the adult population, right? So in majority of adult population, this EBV is present on the lateral borders of the tongue, right? Now these individuals are definitely EBV seropositive, and they are carrier of the disease. Very important, they are carrier for the disease, and primarily homosexual males, right? Again, it might be asked as an MCQ question. So primary in homosexual males. There is a direct infection of Langerhans cells due to HIV induced loss of factor, which are essential for their integrity and function, and that permits reactivation of the EBV with frequent epithelial hyperplasia, right? Now there is epithelial hyperplasia which is occurring, which directly triggers our EBV virus. Moving on towards the clinical features for OHL, the first one which we will discuss is regarding the site, right? So where this OHL is most commonly found. Okay, so it is a very unique and significant lesion which primarily occurs unilaterally or bilaterally. So in most of the cases, that is more than 75% of the cases, you will encounter this unilaterally, right, along the lateral margins of the tongue. However, in few cases this might also occur bilaterally on the lateral borders of the tongue. So apart from lateral borders of the tongue, right, which is our primary site, it can also occur along anywhere over the dorsum of the tongue, right? It might occur in the anterior 2/3, posterior 1/3. It can occur anywhere around the dorsum of the tongue. Second most common site is our buccal mucosa, right? Sorry, our third most common site would be the buccal mucosa. The fourth most common site, floor of the mouth. Then we have the retromolar area, followed by the soft palate, right? So our first most common site would be the lateral margins of the tongue. Second would be the dorsum of the tongue. Third, we have our buccal mucosa. Fourth, we have floor of the mouth, followed by retromolar area and the soft palate, right? So in the exam, you can draw this diagram and show the common sites for the occurrence of OHL. Moving on towards the appearance of OHL, right? So in this figure, you can see it has a corrugated white appearance, right? Very corrugated surface with hair-like projections, and color is white, right? So it has a corrugated white appearance, and definitely it does not rub off. It does not rub off like any other leukoplakia, right? It is a white patch which does not rub off, and it might resemble any type of white keratotic lesion. But the distinguishing fact would be first the location, second would be the history. If at all the patient already tells you that he is HIV seropositive, and the third would be the hair-like surface and the corrugated appearance along the lateral margins of the tongue. Moving on towards another clinical features which is regarding the surface appearance, right? The appearance of the surface of OHL, right? The surface is definitely irregular. It might present with prominent folds or some kind of projections, right? So in this figure we can see this is the lesion, right? So definitely a white keratotic lesion, right, with prominent folds and projections, right? So here you can appreciate prominent folds and projections are seen, and this lesion might resemble hair-like projections, right? Occasionally, in very few cases, that is in less than 2% of the cases, the lesion would appear smooth and flat, right? The lesions might appear very smooth and flat. Moving on further, let's discuss about the spread of OHL. Okay, so they may spread downwards onto the ventral surface of the tongue, right? So we have seen that second most prominent site was the dorsum of the tongue, however it might spread downwards and invade the ventral surface of the tongue as well, and on ventral surface of the tongue this lesion will typically appear flat. This is very important point, right? So on the dorsum it will typically present as hair like and corrugated white lesion, whereas onto the ventral surface of the tongue, when it erodes the ventral surface of the tongue, this lesion typically appears flat, right? So here you can appreciate the difference, right? Onto the lateral margins, typical corrugated appearance, right, with folds very clearly visible, right? These folds or projections are clearly visible. However, onto the ventral surface this lesion appears relatively flat, right? It appears relatively flat. So there is a term given in various textbooks which is pseudo hairy leukoplakia, right? So the term pseudo basically means false. Okay, so sometimes there are certain white lesions which satisfies the criteria for diagnosis as oral hairy leukoplakia. However, we cannot find EBV associated with that particular lesion, right? EBV is not present, therefore it is known as pseudo hairy leukoplakia. Now this might occur in individual with marked immunosuppression, right? So as we have seen that in majority of the cases the EBV is harbored along the lateral margins of the tongue, and whenever the immunity of the individual goes down, right, this type of lesions might occur spontaneously, right? So marked immunosuppression causes OHL in few cases, right, and this type of lesions are not associated with our HIV, right, and EBV is not present either in such cases. So in such cases there is a term given in various textbooks, that is pseudo hairy leukoplakia. Name itself indicates that it is a false type of hairy leukoplakia wherein we cannot find any EBV associated with that lesion. Moving on towards the management for OHL, right? So OHL caused by Epstein-Barr virus, and as it is caused by a DNA virus or virus itself, we are giving antiviral drugs, right? Makes sense? Yes. So we are giving antiviral drugs. So in majority of the cases it is asymptomatic and does not require any medicines, right? So but however we do treat the lesion. Okay, so in a few studies it has been observed that OHL disappeared in patients who were receiving high dose acyclovir, right? That is 2.5 to 3 mg per day for at least 2 to 3 weeks, right? So orally we give acyclovir for 2 to 3 weeks and the lesions disappear, right? So our first line of treatment was acyclovir. Second line of treatment is zidovudine. So these zidovudine capsules are also given in HIV infections, right, to reduce the viral load, and the same is also given in case of OHL, right, to decrease the Epstein-Barr virus count, right? So in HIV therapy, zidovudine significantly produces good effects and there is spontaneous regression of OHL. Moving on towards the treatment options which are available in topical form, right? So topically we can give retinoid, which is ready available in various medical stores, right? It is marketed under the name Tretin, right? So retinoids are given. Apart from it, podophyllene resin, right? We have seen that in cases of leukoplakia also, this podophyllene produces good effects, right? It causes spontaneous regression of the hair-like projections which are typical of OHL. Okay, so two lines of treatment, topical treatment, right? First is retinoid and second is podophyllene cream. So guys, that was all about oral hairy leukoplakia. I hope you understood the topic very well. If you like this video, kindly consider subscribing to my channel. Till then, this is Dr. Snehal signing off. Bye bye. Take care.